Every year, 1 out of every 35,000 Americans are diagnosed with liver cancer. And while it affects slightly more men than women, caseloads are rising. Fortunately, certain novel treatments offer hope and extended quality of life. Joining us today to talk about liver-directed therapy and interventional oncology is Dr. Maureen Kohi, an interventional radiologist at the University of California, San Francisco. Welcome, doctor.
Thank you.
So great to have you here. Doctor, liver cancer is slowly rising. Do we know why?
Well, I think one of the main reasons is because we're getting better at detecting it. So early screening results in early detection and a rise. Another reason is because we're seeing an increase in the risk factors. For example, more people are being diagnosed with viral hepatitis. We have a rise in obesity, in type 2 diabetes. So all of those can account for an increase in hepatocellular carcinoma or liver cancer.
Well, talk about the risk factors for a moment. What are they, and will reducing those factors help reduce the chance of coming down with the disease?
The most common cause can be viral hepatitis. So hepatitis B and C can cause liver cancer down the road after a couple of decades. Another cause is alcoholic liver disease. So binge drinking over a course of your lifetime can cause cirrhosis and then liver cancer. Also, fatty liver disease from obesity or from type 2 diabetes. So trying to avoid viral hepatitis, getting vaccination for hepatitis B, for example, leading a healthy lifestyle,
right.
Limiting alcohol, exercise can definitely reduce and prevent the risk factors and reduce the risks of developing liver cancer.
Okay, talk about some of the novel treatments. Those are good things, specifically liver-directed therapy. What exactly is that?
So liver-directed therapy is a procedure that we do where we inject small beads, such as LC beads, into the arteries that supply the liver cancer. And by doing that, we block off the artery from supplying the tumor oxygen and nutrient, and it results in the killing of the tumor. The problem is that not everyone diagnosed with HCC qualifies for transplant or surgery. So one great novel technology is a liver-directed therapy with the death of the cancer cells, and so the tumor gets smaller, so the patients have more time to get a liver transplant, or the tumor gets so small that the surgeon can finally take the patient to the operating room and remove the tumor, and it will enhance their survival.
Are there any side effects?
Usually we do this procedure in the hospital, and an interventional radiologist performs it. It can be on an outpatient basis, and the patient goes home after a short recovery or potentially after an overnight stay. The symptoms aren't as bad. This isn't systemic chemotherapy. Usually patients just feel a little tired for about a week, or they can have some pain, very mild pain, that responds to medications that we give them. Their quality of life is not changed. They live in their house, they do their activities. You don't need to go to chemo, for example, every week or twice a week or things like that.
Well, that's great news. And is this liver-directed therapy for anyone suffering from primary liver cancer?
There are some specific criteria, so the best thing to do is to ask your doctor if you qualify for a local regional therapy for your liver cancer, if that were to be a concern.
Well, great news. Thank you for coming in, doctor. Such great information. And there's always lots more important information to be found on our website, thebalancingact.com. And of course, we invite you to share by logging on to Facebook/The Balancing Act fans.
Indications: LC-Bead and LC-Bead M1 are 510K cleared by the FDA for the embolization of hypervascularized tumors and arteriovenous malformations, AVMs, in the USA only. Cautions: embolization with LC-Bead and LC-Bead M1 microspheres should only be performed by physicians who have received appropriate interventional occlusion training in the region intended to be embolized. Potential complications: undesirable reflux or passage of LC-Bead or LC-Bead M1 into normal arteries adjacent to the targeted lesion, or through the lesion into other arteries or arterial beds, such as the internal carotid artery, pulmonary or coronary circulations, non-target embolization, pulmonary embolization, ischemia at an undesirable location, capillary bed saturation, and tissue damage, ischemic stroke or ischemic infarction, vessel or lesion rupture and hemorrhage, neurological deficits including cranial nerve palsies, vasospasm, death, recanalization, foreign body reactions necessitating medical intervention, infection necessitating medical intervention, clot formation at the tip of the catheter at subsequent dislodgement.